As I mentioned earlier, to those who were online before I hopefully started the recording, this is our first conference migrating from WebEx to Zoom. And so I hope everything will go smoothly. Time will tell. Let's see, here we go. So this session is titled Adventures in Neuro-Oncology, Neuro-Oncologic Diagnostic Medicine. I hope everyone's going to have a good time and learn. The key is to have a good time. Okay, warm up. We always do a warm up, and we're going to do something a little bit different to start. Clinical symptom challenge. So, typically I'll do MRI challenge, CT challenge, genomic signature challenge. This is going to be a clinical symptom challenge, and I'm going to label it a 301. That'd be like a junior level challenge. And the question is, what was the patient's chief complaint? And I'll show you an image in a second. And it's a clinical challenge. What was the patient's chief complaint? Warning, if you can read the asterisk, I put it in really small print because I didn't want to scare anyone. Some knowledge of neuroanatomy will be required to play this game. Ready? Here we go. What was the patient's chief complaint? Okay, I'll give you a second here. I don't, does the chat function work? I'm looking for chats, I don't know. Okay, it may be that it's different from WebEx. That's okay. All right, have a look. Does anyone have a chief complaint? Okay, the answer was nausea and vomiting. Question, why? Why nausea and vomiting? Give it a few seconds, think about it. All right, here we go. I've identified the lesion in sagittal and axial T1 with contrast. And why nausea and vomiting? And the answer is, the lesion is right at the obex. All right, the obex is the caudalmost point of the floor of the fourth ventricle, where it transitions into the central canal. And the neuroanatomy is critical. So where I always go for neuroanatomy and neurohistologies, of course, histology for pathologists, 5th edition, Fuller and Ballister. And here you can see an illustration from chapter 9 showing the obex at the junction between medulla and cord. And here's floor of the fourth ventricle, neuroanatomy, starting rostrally, facial colliculus, the stria medullaris, which divide the rostral from the caudal halves of the floor, the diamond-shaped floor of the fourth ventricle. Then from medial to lateral, hypoglossal trigone, vagal trigone, and area postrema, and that is the key here. And then the obex in the midline, area postrema, bilateral circumventricular organ outside the blood-brain barrier, AKA, also known as the emesis center of the brain. And here is the tumor, a small tumor precisely placed at the obex, influencing the area postrema and leading to nausea and vomiting without the presence of obstructive hydrocephalus. Now, I believe, according to the, let's see, there's the key. According to the patient's neurosurgeon, Dr. Ian McCutcheon, this is, I think he said, the 3rd such patient with this diagnosis of a small tumor at the obex leading to nausea and vomiting, disrupting the micromilieu of the area postrema. Okay, what is the diagnosis for the case? That was the answer to the challenge of the question of what was the presenting symptom. What is the diagnosis? Now, many of you may have noticed what's circled in yellow. I'm sure every neuroradiologist noticed it. Clearly, this is a craniotomy defect. And so something has been done here before. Let me show you a couple more images. This is a slightly different sagittal cut. And now you can see at least 3 different lesions. The original lesion we looked at the obex, plus an additional one in the cervical spinal cord, and then one in the cerebellum. Plus, we know that there was a craniotomy defect, so that's at least 4 lesions. And the question for you then is, what is your diagnosis for this patient? You have a second to think about it? Okay, here we go. This is hemangioblastoma of the obex arising in a setting of von Hippel-Lindau syndrome. Did you like that? That was a pretty good warm-up, wasn't it? Had a little bit of everything, some neuroimaging, neuropathology, clinical symptoms, inherited tumor predisposition syndrome. Okay, I'm very excited to announce a new conference feature, and I'm going to title this series, What is Wrong with This? And as I've said many times in the past, whenever I introduce a new conference feature, I'd say there's about a 75% chance that it will never show up again. But in this particular case, I think that, it's likely to show up. So the question is, what is wrong with this? All right, you ready? Here it is. You have a look at it. What is wrong with this? Okay, this is a diagnosis, and I've added to the diagnosis, I've added as I saw it in a referring institution report of the other critical or significant molecular alterations. So this is essentially the diagnosis plus some molecular alterations. Okay, so I'm going to have a look at it and see what you think. Okay, here we go. You know, it might be easier to say what is not wrong with this diagnosis. There are so many things wrong with this diagnosis. How many did you spot? All right, let's have a look at them. Here's the first thing I saw, Roman numeral 2, diffuse astrocytoma, WHO grade 2. That is so WHO 2016, a 5-year-old classification. That is a lifetime. It's a geologic epoch ago in terms of brain tumor classification and biology. So here is the 2020 cIMPACT-NOW update 6, in which we are officially changed from Roman numerals to Arabic numerals. And here's the paragraph from that paper, grading Arabic versus Roman. The fact of the matter is, all of the other volumes of the quote Blue Book series, that's the WHO classification of tumors by system, by organ system, all of these use Arabic numerals, and we're going to do the same. So Roman numeral 1, 2, 3, 4 are gone. The Arabic numerals 1, 2, 3, 4 are in. There's no reason to use Roman numerals since the cIMPACT is out there. For all of the classification systems and alterations that are in the 7 cIMPACT update papers, you can begin using them now, pathologists, in your reports, and simply reference, if you feel the need, according to the cIMPACT update, 3, 5, 7 criteria. All right, and these criteria will be reproduced, adopted by the 5th edition of the WHO. All right, what else is wrong with the diagnosis? Diffuse astrocytoma, all right, and it's IDH mutant. You see further along, IDH mutant. We will no longer be using that term, diffuse astrocytoma, for IDH mutant diffuse astrocytic disease. All right, so here's the, this is from brain pathology, nomenclature for diffuse astrocytoma, IDH mutant, grades 2 through 4. Here's the table that's accompanying it. And again, this is from cIMPACT. Look at the titles of the 3 grades. Astrocytoma, IDH mutant grade 2. Astrocytoma, IDH mutant grade 3. Astrocytoma, IDH mutant grade 4. Here's the corresponding 2016, or revised 4th edition nomenclature. Diffuse astrocytoma, anaplastic astrocytoma, glioblastoma. Gone. History. Their history now, according, you can reference again the cIMPACT update paper, totally gone. Diffuse anaplastic glioblastoma. You like that? Okay, that's good. This is all review. We've covered this before. I just want to make sure everyone's up to speed. All right, what is wrong with this? IDH, well, you could say they didn't specify 1 versus IDH2. We should put the 1 in, and then mutant and PA132G. Okay, I'm going to acknowledge now the Senior Dawn of Head and Neck Radiology at MD Anderson Cancer Center, the incomparable Dr. Larry Ginsberg. As you can see, he's a Yayin Lee Professor of Head and Neck Diagnostic Radiology. One of the things that Dr. Ginsberg does regularly in his exquisite head and neck, oncologic head and neck conference is to acknowledge when he has made an error and presents those cases. Now, it takes a very strong ego to get up and acknowledge an error in front of an audience. It's very important that we do this so that everyone knows that no one is perfect. Everyone can stumble, and the important thing there is that you don't trust anyone. Don't trust me, don't trust whoever your favorite authority is, whether it's radiology or in pathology. Okay, I made an error, in this case, live action at Tumor Board this past week. And I'm going to run through the error that I made, and we're going to do a root cause analysis. All right, what's wrong with this? So what you can see, IDH1, P, the protein A132G, that is extremely odd. That is a very odd point mutation. And you know, the very first thing that I thought about this, the 132, it didn't register fully with me because of the A and the G, that is residue in the protein. It's residue 132. We're going to talk about it in just a second. All right, the A was totally foreign, okay? And the whole thing all together suggested to me, maybe this was a non-pathogenic SNP because it wasn't one of the normal canonical or non-canonical, all right, binding site mutations that lead to the pathology, the 2HG generation and the whole oncogenic pathway. And one of the issues was the clinical course of this patient was not what one would have expected for classical IDH mutant disease. All right, I'll explain that in just a second. So there was an issue, and I was searching for an explanation, and I latched onto this. Maybe this is a non-pathogenic SNP, which was reported, and it was misinterpreted as an IDH mutation. That has happened in the past because the mutation affected a part of the protein which did not, is basically silent, essentially a SNP, non-pathogenic, and I latched on to that hypothesis. All right. Well, let's break it down. And I did that publicly. That's what I said. It was the very end of the conference. The conference ended, and then I got to work digging around to figure out what was my mistake and what was going on. And I'm going to lay all of that out for you, and hopefully this will be instructive. All right. The first question, the PDOT, this is a protein. So we're talking an IDH mutation in the protein, residue 132A. Question, what is A? The A and the G are the two amino acids. What is A? What does that stand for? Well, here's the table of abbreviations for amino acids. If you are not familiar with them, there are 3-letter codes and 1-letter code. Both are frequently used in the nomenclature for genomic alterations. Some institutions in their reports will list both the 3-letter and the 1-letter. The 3-letter codes are easier to recognize unambiguously, immediately, intuitively, if you will, user-friendly, what the amino acid is. Let's just look at the four amino acids that all start with A. Obviously, for a 1-letter abbreviation, all 4 of them cannot have A. Well, who got A? Alanine. Why? They're alphabetical. Alanine, arginine, asparagine, aspartic acid. That is alphabetical listing, these 4 amino acids. And alanine, first in line, gets the A. All of the others, arginine, R, that should ring a bell to everyone in this conference. Yes, R. Asparagine, all right, N, and aspartic acid, D. And you can see the rest. It's all unique 1-letter code. Now, if you are unaware of the 3-letter and 1-letter abbreviations and you didn't have the table, now you do. So that's a cool thing if you're not aware of it. All right, and then again, alanine in this particular mutation, as in the referring institution report, alanine is A. So what this is, the A is alanine at 132. All right, and the problem is that cannot be wrong. Cannot be right. That cannot be right in any way because at residue 132, the residue, it is arginine. It is always arginine. That is the normal. And there is no SNP, single nucleotide polymorphism, that I'm aware of that I could find that places an alanine there. And if there were, it probably would be pathogenic because it is at a critical active site within the protein. So it simply has to be wrong. All right. And yeah, and so my hypothesis that this was non-canonical, that it was a non-pathogenic, totally wrong. All right, what the patient actually has is an R132G. Now, R132H, that is histidine, replacing the arginine at position 132, that is a well-recognized non-canonical, which means less common, but extremely well-known, well-recognized. It's one of the major non-canonicals, and that's what this patient has. So it is, in fact, an IDH mutant diffuse astrocytoma. All right, so arginine 132. All right, so why in the referring institution report, is it listed as P.A132G? It's just a typographical error. It is just a typographical error. And it's just wrong. This is the actual, it's anonymized, totally anonymized. And you can see here in the interpretation of the IDH1 mutant detection assay, it's positive. There's evidence of an IDH1 point mutation is indicated by the nucleotide change in codon 132, CGT to GGT, all right, which would be C394G, all right, and then they translate that into amino acid, ARG132 glycine, arginine to glycine, and then in parenthesis P.A132G. Now, when that report carried over into our clinical record, the ARG132 gly was not used, only the P.A132G. Oh, okay. So, how could I have made such a moronic error as to think IDH1 P.A132G might be a non-pathogenic IDH1 mutation rather than just instantly recognizing it for what it was, a simple typographical error? How did it happen? All right, let's do an RCA, root cause analysis. This is extremely common, mandatory in industry. Every successful company does RCAs for major disasters. And because it was personally humiliating to me, I'm going to call this a major disaster. Okay, you have to be able to laugh at yourself. Listen, if you can't laugh at yourself, and there was no harm done here to the patient itself, if you can't laugh at yourself, it's going to be a long life. Okay, let's do the RCA. What were the factors that contributed to my error? Number one, this was an add-on case to tumor board, which means it came late, and I didn't have time to study and understand the patient before the conference. A lack of adequate preparation. And notice, I didn't say I didn't have time to look at the pathology or to look at the report, look at the diagnosis. I did not have time to study and understand the patient. And this is something that I emphasize as everyone that's that's rotated through neuropathology or has been attending this conference for any length of time. What we emphasize for diagnostic imagers and diagnostic surgical pathologists is you must understand the patient, where they are in this journey through the disease they're experiencing and exactly what is going on. All right, and that is what will protect the patient. You need to understand all of the 8 Venn diagram data spheres, which when taken together will help you not to make a mistake and arrive at a precise diagnosis. And we will go through the Venn diagram. Maybe next week we'll go through that again, that model. All right. Secondly, I did an on-the-fly hurried fact check of the electronic medical record while the conference was running. Once I noticed that signature, and it showed that in the EMR that this unusual signature, all right, A132G, was recapitulated in several different areas of the EMR. It was in the history physical, it was in the clinical summary, so that gave legitimacy to it, right? Legitimacy. Now, what it actually was? This is called cloning. It's a form of cloning. It's propagation. Listen. Propagation of error when data is repeated without knowledge or any sort of vetting by whoever's repeating, yada, 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 right? Or critical thought. And that is why clinical record cloning is a big no-no. Now, the typical instance is where you take the patients come into clinic for follow-up and you just cut and paste a big chunk of the history and just accept it verbatim. And this would be, you are not the one who wrote the original clinical history. You're just taking it for granted that it's true. And it leads to all kinds of errors, including propagation of errors in the clinical record. So this is an excellent case study in propagation of error. See, this case is informative on so many different levels. All right, here's another factor. Okay, the clinical course, as I mentioned, of the patient was atypical of that, of the typically indolent IDH mutant diffuse astrocytic disease. In fact, it was development of massive secondary gliomatosis cerebri, an entire hemisphere plus going over to the contralateral hemisphere. Not typical for IDH mutant disease, which you expect to cook along, indolently for years, decades, even. All right. So I was looking for an explanation. I was grasping at straws. How can I describe this? That's good. That's good. An analytic mind wants to understand it. All right. The non-canonical nature of the mutation. So it was a G, not H. contributed to the strange, I'll just call it a strange feel of A132G. And I didn't immediately snap to the fact analytically that 132 was the residue, that was the amino acid, which would be altered, any alteration there. And then the G was one of the most common non-canonicals. I didn't put that together. If it had been the canonical mutation, R132H, and A had been substituted for R, so it was A132H, I think that would have been easier to instantly gestalt, oh, it's just a typographical error. That should be R132H. That would have been easier. All right, but no, what are the odds? What are the odds that this case that's going to come along and give me a problem, it has to be a non-canonical? It's like two things. It was a non-canonical and there was a typographical error, and the combination gave it a strange feel. I'm working on the fly, trying to come up with an explanation. Okay, a quick check of the initial presentation referring institution MR imaging, which I was doing on the fly again. Conference is going on. I minimized the conference. I'm going through the clinical record, trying to figure out what's going on. And I went back to the initial referring institution imaging study, pre-operative, pre-treatment, and there was no T2 flare mismatch sign. Now, that doesn't mean that it's not IDH mutant. It just means that because the negative predictive power is lousy, it just means that it was not an instant confirmation that it was IDH mutant disease. Again, here's a third thing that contributes. Talk about perfect storm. This is a perfect storm. If the initial presentation imaging had shown a classic T2 flare mismatch sign, then I would have instantly known this is IDH mutant disease. And I'm going to figure out what that was, but I would have known it's not a non-pathogenic. I would have known that because the T2 flare mismatch sign, when present, has a 100% positive predictive power for IDH mutant diffuse astrocytic disease, as we've covered many times in this conference. Isn't this cool how all of these things are building up to make me make a fool of myself tumor board? Okay, let's see. Okay, so what I do, I hastily cobble together an hypothesis that the atypical clinical course might be explained by a non-pathologic IDH1 mutation, which would mean that was an IDH wild type disease. And the preoperative imaging with the absence of a T2 flare mismatch sign did not contradict that hypothesis. So being hurried because of the case under active discussion, I failed to notice. Let's see, here's another thing, because I was working quick under pressure because I knew it made, if I was going to comment or raise the issue, I needed to work fast, raise the issue. I failed to notice that the initial presentation was 2015. That scan I was looking at was 5 years ago, which would fit very well with IDH mutant disease. Even though the later course is still unusual, still 5 years, to progress, that's much more likely to be IDH mutant disease than IDH wild type disease. Okay, so I fell in love with my hypothesis, and there it is. That is a huge lesson here. First lesson is whenever you're hurried, whenever you're rushed, whenever you cut corners and you don't have time to be thorough, you're going to make errors. You're going to make errors. Now, thank goodness in this particular case, there was no downside whatsoever for the patient. In fact, the upside was I am able to present it to you and we can discuss some of the reasons why errors happen, serious errors, misdiagnoses happen. All right, so rushed is one. This is another one, falling in love with your hypothesis. Now, this is something that I learned in my first year of graduate school. Do not fall in love with your hypothesis, laboratory hypothesis. You propose a hypothesis, you formulate a hypothesis, and then you test it. And by testing it, I mean the crucible. I mean fire that melts metal so that the impurities will rise to the top. You have to put your hypothesis, and this is going to be your diagnosis, right? Radiologist, pathologist, this is your presumptive diagnosis. When you look at the scans, when you look at the histology, when you look at a complex molecular signature, you formulate a hypothesis. You must subject your hypothesis to the crucible and try to prove yourself wrong. The truth of the matter is I wanted it to be a non-canonical because, not a non-canonical, I wanted it to be a non-pathogenic mutation because it would fit with explaining the atypical clinical history as such that it blinded my otherwise fairly decent analytic powers, and I didn't recognize the 132. Okay, let's summarize. Two common errors that surgical pathologists and diagnostic, two common errors of surgical pathologists, diagnostic radiologists. Making a snap judgment diagnosed based on initial impression and not thoroughly and critically examining all of the data. Falling in love with your hypothesis, that is always a mistake. We take one quick look and we see whorls and we think, oh, meningioma, done and done. What it actually is metastatic melanoma, amelanotic melanoma, which can mimic meningioma beautifully in some cases with these gorgeous cellular whorls. But you know, you're in a hurry. It's a dural-based lesion. Let's just call it meningioma and move on. All right, and then the second one is overweighting, giving too much weight or importance without any scientific evidence, no scientific validation to a single datum, to the exclusion of the others. Well, I think this tumor is meningioma because it shows whorls, well, but it has the whorls. And you say, no, but what about this? What about this? What about this? Which are odd and atypical. No, look at the whorls. That is what we tend to do, whether we're radiologists or pathologists, and you have to guard against it. It's like it's inherent in us to do that. Okay, datum. This is going to be the word of the week. There's got to be at least one person in the audience who knows data and doesn't know the difference between singular and plural, does not know that data is plural. So we would talk about these data, you know, plural. A datum, here we go to the Google English Dictionary by Oxford Languages. A datum is a single piece of information. A whorl, you know, enhancement, the sickle sign in neuroimaging, something like that. Okay. Okay, that was a pretty good warm-up, and I feel relieved. This is cathartic, you know. Now that I've laid my soul bare here about this error I made, tumor board, I think that's why Dr. Ginsburg does this, you know. And it also, again, it lets everyone know that no one, no authority, no textbook, no paper in the literature is above error. Always be skeptical. Okay, let's move on. How about an MR imaging challenge of the week? Okay, we're operating at a pretty high level already in this conference, right? Let's make this a professorial level challenge. Now, professorial means I am asking, we have several full professors with decades of experience, both in neuroradiology and in pathology attending this conference. This is one, everyone needs to be challenged, right? From the very beginners to the most experienced. So let's make this a professorial level, and we'll see if any of our neuroradiologists can get this one. All right, now here's what I'm going to show you the image in just a second. The image is coming next. All right. Here's what I want to know. What entity is at the top of your differential diagnosis? I'm not saying the image is pathognomonic. It's absolutely not pathognomonic. I just want you to identify and study, look at the lesion. Look at the lesion, and I'll tell you it is a tumor, and what entity, what oncologic neoplastic entity is the top of your differential. Are you ready? Okay, let me apologize in advance. This is a professorial challenge. Okay, here it is. And because it's professorial, I'm going to give everyone, I'm going to give you about 15 seconds to study it, and I'm hoping that will be, I'm hoping that it's going to be informative if someone gets it, okay? And I think that evidently, I apologize, I participated in hundreds of Zoom meetings, and I've recorded Zoom lectures. It's the first time I've run one, and I don't exactly know how to work the chat, and maybe we'll allow people to unmute. I think we'll try that in a future. Okay, all right, that's it. 15 seconds, that was my timer. 15 seconds are up. If anyone got this, identified it correctly, why don't you email me, gfuller@mdanderson.org after the conference, and I will give you credit the next one. Okay. Would you like to see the case if you didn't identify it at the 301 level? I'm gonna make it a little bit easier. Still not easy, but it's a little bit easier. And what I've simply done here is coned in on the area of interest. And I'm gonna give you a minute here. I called it 301. I'm looking at it now, and I'm thinking it's actually a 201, more like a sophomore level question. Again, I would like for you, if you got it at the sophomore level, please email me, let me know. I would like to know that. Okay, and all right, anyone up for kindergarten level? Because I want everyone to be a winner at this conference, okay? So let me show you the exact tumor, the exact scan, kindergarten level. How's this? Okay, myxopapillary ependymoma, absolutely. Can you see it now? Take a second to study it. Is it even possible to identify it on the scan? Yes, absolutely, but you have to be thorough. You have to go from top to bottom. You may have noticed something going on up here in the neck, maybe prior surgery. I don't know. It's hard to say, but you have to be thorough. If you latched onto this, if you latched onto that and didn't get away from it, that is not how you be meticulous, and you're going to get into huge trouble. Did you study the brain first at the very top, looking at the head and neck? We're working all the way down, all the way down, all the way down. And what is going on here? That is a question. All right. So here I've numbered the vertebrae starting with T12 and L1, 2, 3, 4, 5. Okay. And look at this at T12, L1. All right. That's into the spinal cord. That's conus medullaris. But look at this. You see the cord is extending all the way down to between L2 and L3. How is that possible? There's the conus phylum. That is not possible. All right. So again, have a look at this. Can everyone see right here? Here goes the conus coming down here. This is where the phylum starts, and look at this big oblong mass. Everyone see it now? Yeah. Now, because it's not showing up, because of T1, it's inapparent. But that is the eye for detail. Now, neuroradiologist is going to be all over this, experienced neuroradiologist. It's harder for those of us who are not steeped in that tradition, but we can develop that skill just as neuroradiologists can develop a high degree of skill looking at H&E images and manipulating complex next generation sequencing output, right? And that is the goal. The goal of this integrative diagnostic medicine case conference is that everyone arrives at the same level, whether you are radiologist, pathologist, a primary care physician. We all can speak the same language, and we will practice our art at a high level, not an introductory, isolated silo level. That is the goal of this conference. Okay, and again, just showing the arrows, the transition, and there it is. 3 different scans, 3 different sequences. It just occurred to me, how did this make the conference? All the cases I present, as everyone knows, are from this past week or 2 weeks, since the last time I gave the conference. I didn't dig these up from a study set. They're not coming from the literature or anything like that. These are all recent cases, and I'm looking at look at that scan on the left, and it just struck me how invisible that tumor would be if you didn't already know it was there. And I thought, well, let's make a challenge out of it, and then we can make it easier and easier and easier. All right, did you like that? Okay, let's try another one. I really enjoyed that. That was a lot of fun for me. Okay, let's do an MR imaging IPR, and another one, and we're going to vary it a little bit. What I want to know is, and this is easier. It's easier. It's no longer professorial. I would say it's probably a 201 actually, sophomore level. And what I want to know though is I don't want to know the name of the tumor. I want to know what is the most common molecular signature displayed by this tumor. Now, what that's called in test taking, when you design tests, when you don't ask the first order, first level question, like you show a picture, what is this? It's an apple. What you would ask something like, I don't know, what is the drink that comes from, what you're about to see, and it'd be apple juice or something like that. So I want you to tell me, what is the most common molecular signature, most frequent molecular signature displayed by this tumor? Okay, everybody ready? Honor system. All right, here we go. Give you a few seconds to look at it. What is the most common molecular signature? Have you got an answer? All right, formulated your answer. All right, here we go. The answer is NF2. NF2 mutation is the most common molecular signature. This is a sporadic retroclaval meningioma. All right, and one of the ways that you know that it's extraaxial, it's not like a pontine lesion, is look at the T2 hyperintensity in the CSF cleft. All right, you like that? Okay, and then here's just with the T1 post on the right. So you have T2 sequence on the left, T1 post on the right. Okay, and then here's a nice sagittal, like so. This is a large retroclaval behind the clivus. So here's the clivus right here, a very large retroclaval, and it's severely compressing the pons. Okay, now why did I show this case? I showed the case because I wanted you to mistake the patient's tumor under discussion on the left for the tumor on the right. I was really hoping someone would think this is this, yeah? And if it had been the tumor on the right, what would have been the answer to the question of what's the most common signature? And the answer would have been H3K27M mutant. So this is a comparison of a large retroclaval meningioma about the size of the normal pons, all right? behind the clivus where the pons is, and a pontine glioma, diffuse intrinsic pontine glioma. In this particular case, proven diffuse midline glioma, H3K27M mutant. All right, now that's kind of an elementary, but basic mimic. But I thought it was very important to put it in here because I'm sure at least if even one person attending this conference looked at that and thought that pontine glioma is the anatomy, et cetera, then it's been worthwhile. It's been a good conference. This is how detail oriented you need to be. Pay attention. Everything must fit. And if you get that, the sense that something's not right, we all have that. Something is not right about any situation. Walking through a parking lot, listen to it. When you're looking at images, whether they are radiology or histology, and you've latched onto a diagnosis, but it's not quite right, pay attention to that feeling and go deeper. Look at the other areas. Okay, let's do a diagnosis IPR, instant pattern recognition, all right? And I'm gonna vary it just a little bit. What I want to know is, I want to know what is the World Health Organization Central Nervous System 5th edition diagnosis. Maybe it'll be known as WHO 2020. Comes out in a few months. We'll see. I think they're referring to it. A lot of the chief editors are referring to it as the CNS5. I've been calling it the 5E for 5th edition. We usually refer to the year, WHO 2000, WHO 2007, okay, anyway. Okay, you ready? All right, this is an instant pattern recognition, and I want to know the 5th edition diagnosis, what you would write in your report, the formal name. Got it? All right, here we go. Okay, everybody got it? And this is going to be the honor system. The honor system means, again, if you got this, if you nailed it and you knew what I was doing and the whole bit, then shoot me an email and let me know. Okay. There's only 3 images that have any relevance to my question of what is the diagnosis. These are the 3 images, and these are the parts of the 3 images. This is the only thing in the 6 images that is relevant to the diagnosis that hands it to you, all right? This is a T2 flare mismatch sign. So you can see on the 2 T2 flare images in 2 different planes, a hypo-intense central region with a hyper-intense rim, and you can see on, I believe it was a gradient echo that I showed at the bottom right, you can see homogeneous on T2. Any of the T2 flavors will do. Don't be particular, right? Should we go back just a second? Here we go. Let's go back. Yeah, see it in all its magnificence. Got it? Okay. Oh, that's a DTI. That's a DTI, isn't it? Yeah. Okay, here we go. T2 flare mismatch sign. So what I was looking for is astrocytoma IDH mutant. That is absolutely correct as a diagnosis. Now you might say, how do you know it's not an anaplastic astro? Because we don't use that term anymore for IDH mutant disease. It's astrocytoma for every grade, including 4. Astrocytoma, IDH mutant, grade 2, grade 3, grade 4. Do you like that? Oh, yeah. Okay. Were you distracted by the colorized DTI, diffusion tensor imaging, fiber tractography, and the functional imaging? Did that distract you? Well, I hope so, because that was the point of the exercise. All right, in a sea of facts, you have to learn to focus and to discriminate between distractors and critical elements, right? Break it down. Now, all of the DTI stuff here is used for pre-surgical planning. It is beautiful. It's neuroanatomy. It is magnificent. And it is informative in some cases, yes, for the diagnosis, whether the tracts are pushed aside or if they are infiltrated. That can be biology, but we're going for something fast. I call this an instant pattern recognition, right? Okay, and the functional imaging, again, is not going to give you this diagnosis with a molecular signature, all right? So you must be disciplined, you must be methodical, you must be thorough, and you must hone in on what you know, right? Did you like that one? That was fun. I've done this before with this exact example. So this is the second. There was other distractors, right? In fact, it's the 3rd time I've done it, because the initial thing I did is I think I showed a sagittal with the T2 flare mismatch instead of a typical axial, right, where you're used to. So that's just a slight variation. But again, all of us need to get used to seeing the spectrum of morphology, and certainly in 3 planes. Got it? Okay, let's do, we're still warming up here. Let's do a genomic alteration IPR. All right, that's kind of a fun thing that we do. You ready? Okay, and what I want is a diagnosis. Here we go. What's your diagnosis? I'll say the most likely diagnosis, most common diagnosis. What is at the top of your list for a diagnosis here? Okay, everybody got it? Answer, diffuse midline glioma H3K27M mutant. All right, and it's this the alteration here. Let's go back a second. There's a TERT mutation that was a TERT promoter mutation. There's a TP53 mutation, TERT promoter mutation, TP53 mutation. That could be glioblastoma. That could be oligodendroglioma. It could be a lot of other things. All right, but the H3F3A, that's histone H3. That is the one that says, oh, this is something special. And there are several tumors, other tumors, non-CNS tumors, certainly which have H3 mutations for sure, et cetera, and peripheral nerve sheath tumor, et cetera. But in our world, this is what we're going for, right? Most common, all right, statistically most common. All right, and I've circled, it's usually the H3 mutations can be one of two different genes, the H3F3A or the HIS1H3B. It doesn't matter, either one are mutated, it's gonna be H3K27M mutant, got it? Okay, and so this is from the NGS at MD Anderson Oncomine V3 platform, and you can see there's the details of the alterations. You always have to look at the segment, the findings immediately underneath, and it clarifies what the alterations are. And here you can see that it actually is an H3F3A K28M mutation, okay? K28M, K27M, what is K28M? What is that? Does it count the same? Is it a non-pathogenic? If it's one residue off, it's not 27, it's 28. What's the explanation? I know several people in the audience, probably many people in the audience know this. I want everyone to know it. It's the exact same thing with G34, all right? Diffuse glioma, G34 mutant, right? Which will be formally codified in the forthcoming WHO 2020. It's the same thing. The answer to the question is they are identical. It's the same mutation. They are not different. And you say, well, how can that be? It's two different amino acid residues. And the answer is it has to do with the early discovery of the histone proteins, right? And the naming convention. So here's a nice paper, 2018, Active Neuropathologic, K27 and G34 versus K28, G35, and histone H3 mutant gliomas. Note of caution. All right, here we go. The enumeration, the numbering of histone amino acids is based on the initial papers that disregarded the first methionine, right, the first residue, because it's cleaved very early in post-translational state. In other words, the minute that the RNA is translated into the protein, the first methionine is chopped off. So when they're isolating the protein, sequencing the protein, numbering the protein, they miss the methionine. So it's only 27 residues in the protein, but 28 in the coding sequence. That is the answer. Question, therefore, knowing this, should we change the entity names? Should diffuse midline glioma, H3K27M mutant, be diffuse midline H328 and G34 mutant to G35? Should we do that? Well, in one paper, that argument was made. In the paper I just showed you, and they said, you know, there is a precedent for changing the nomenclature for a pathogenic mutation. BRAF V600E was not always BRAF V600E. It was formerly BRAF V599E. It's exactly the same situation, the early cleaving of the first amino acid residue. And everyone knows BRAF V600E. I mean, in your sleep, you know that. Now, BRAF V599E, not so much. It's disappeared, right? The transition was made, all right? Well, here's from what does cIMPACT say now? What should we do? Here's the statement from cIMPACT with respect. There remains debate as to the best numbering to be applied to the molecular defect mentioned in the name of these tumors. That is, whether to follow the amino acid numbering, so G34, or the DNA codon numbering G35. And it's the same thing for K27, K28. So we'll see. I can tell you there was very interesting debate in Utrecht at the consensus, the planning consensus conference. there were advocates on both sides. The advocates for keeping K27 and G34 is that it is entrenched in the literature, especially in the neuro-oncologic brain tumor research. It is entrenched. Why change it? It's like medulloblastoma. There's no such thing as a medulloblast. We kept the name. There was a movement to call medulloblastoma just primitive neuronal, primitive neuroectodermal tumor, posterior fossa. It didn't fly. That was a fleeting trend. Maybe we shouldn't switch. I will call them the progressives. The progressives said the truth is it's G35 and K28. And moreover, virtually all, I would say, I'm just go ahead and say all. You never say all, but I'm going to say all of the corporate NGS companies have switched. Foundation One, you know, all of them. And I think it looks like MD Anderson. I guess we've switched too from this case to reflect the truth, just like with the BRAF V600E. I can tell you, I have received questions from both patients that read the report and are savvy because the internet, we can look all of this up on the internet, and from pathologists in the community, which say, you know, this, you know, my NGS report, you know, from the reference laboratory says it's a K28. What does that mean? And the answer is, it's exactly the same as K27. So here's what's important. Listen, here's what's important for all of us, everyone listening. What's important? It doesn't matter if they switch from K27 to K28, G34, G35. It doesn't matter to us because we know the truth. We understand it, so it's not a mystery. Isn't that fantastic? In fact, you are now empowered. If you did not know this before, you are empowered, right, to disseminate this information to your colleagues, to patients, to whoever inquires. Plus, think about this for just a second. The next time one of your patients presents with one of these two tumors, either diffuse midline glioma or the diffuse glioma G34 in the hemisphere, typically in a pediatric young adult. The next time you do, look at the NGS report and see what the actual report, which way they go. And I guarantee you it's going to be the K28 and G35, but it gives you something fun to look for and be thorough. Okay, was that good? All right, patient number one. Okay, I think that's enough of a warm up. You think? Let's see what I've got. 347. As it seems like it's been my trend for about the last 10 conferences, even pre-COVID, that there's just so much to cover with these warm ups. It's all these little incidental things that come up over the course of a single week. All of this stuff we're talking about, it's all last week. Actually 2 weeks. Well, it's 2 weeks. I had 2 weeks to choose from because I was on service last week and we couldn't hold a conference because I could get called a frozen section. But I could have done I had enough material for 3 conferences for 3 hours. All right. It seems like there's so many things that come up that it's hard to go back to the old patient one to take more time. But we're going to do a patient right now. Let's do patient one. I only have one patient, 66-year-old male, and this comes from the files of Professor Campbell. This is Professor Jerry Campbell, MD, PhD. All right, Director of Anatomic Pathology and Chief Neuropathologist at UTMB Galveston, a good friend of mine, and we are actually brothers in the F. Stephen Vogel, Peter Berger family from the Duke era. And those were the best neuropathologists. What happens in this conference stays in the conference, right? So I'm going to pick Duke over Hopkins, the Berger Hopkins. Now let's move on. We got trouble. Okay, here it is. Study it. Histology first. Okay, let's go to higher power. Give you a minute to think about it, analyze it. Okay, everyone got it? What was one feature of the pre-op imaging? Just tell me from what you just saw, can you tell me one, I'm going to call it a morphologic feature of the pre-op MRI scan, okay? Hopefully you've arrived at a diagnosis, and this is the feature. This is a little bit higher power. This is the feature that I wanted you to zoom. Oh, this is how appropriate, to zoom in on. That was an intended pun. What is the feature? And I know there's a bunch of the pathologists that are all over it. What I'm hoping is a bunch of the radiologists are all over it, because I've talked about this. Over the last 2 years, I've probably had at least 5 or 6 cases. And the answer is it's cystic. It is absolutely cystic. I don't know if it's one big cyst. I don't know if it's a multiple small cyst or if it's just one cyst. It's not a microcyst. It is a macrocyst that will be visible. It will be visible on imaging. Why? Because this is a smooth pseudoepithelial lining. You see how smooth and undulating this lining is? Along here, along here, along here. And there were multiple fragments that exhibited this smooth lining. Now, if you look, this is not a true epithelium. You up to high power here. It's not squamous or cuboidal or columnar or urothelium. It's none of that. It's actually the tumor going all the way up, but it's been compressed by the pressure of the cyst fluid, flattened into a pseudo line. It's like a pseudo capsule. That's what a pseudoepithelial cyst lining is. It's essentially a pseudo capsule, which is compressed connective tissue, etc. Only instead of being a pseudo capsule around a solid expanding mass, it's a pseudo capsule around a solid expanding mass of water around a cyst. And this, the presence of a pseudoepithelial lining, tells the pathologist the tumor has a cyst. And that can be important in diagnostic medicine for brain tumors, because there are certain tumors that tend to have cysts frequently. Pilocytic astrocytoma, angioblastoma, right? Okay, so that's what it says. All right, and let's see. Here we go. Okay, the next thing I'm going to ask you is, what is your diagnosis? So there's a bunch of different tumors, like we just said, that can have a cyst. Yes. The question is, which one of those is this? And this is a super high power for you to hone in. Let me study it for a second, put it together. So diagnosis. What is your diagnosis? Putting the preoperative imaging morphology together with the histologic morphology, what do you arrive at? Cystic schwannoma. Cystic schwannoma. Would you like to see it? And here it is. Beautiful T2 sequence showing this is a giant cyst compared to the size of this typical spinal schwannoma, dumbbell tumor going through the foramen. How gorgeous is that? Do you like this case? I could have started it either way. Many times it's difficult. I don't know how to play the cases, right? I just have to choose. This would have been a great scan to start with, wouldn't it? And in fact, maybe I'll do that in 6 months and see if anyone remembers it, right? We will start maybe a slightly different cut, and we'll see if anyone remembers it. Isn't that great? Cystic schwannoma. All right, you have cystic meningioma, cystic everything. Okay, guess what? There's only one case. This is the case. We're not done. I still have 8 minutes. 3:52. What is this? It was only present in one tiny microscopic, not macroscopically visible, tiny microscopic focus. Here's a little bit higher power. That's the craziest looking schwannoma I've ever seen. So I guess it's a malignant schwannoma. That's incredibly rare. For schwannoma to progress to malignant peripheral nerve sheath tumor can happen. But it's a different animal. It's a different biology that leads to that. It's 99.9% of the time, it's neurofibromas that progress to NPNSTs. Is there a variant of schwannoma? Is this an epithelioid schwannoma? Oh, I'm not really comfortable with that. I don't know if everyone can see. I don't know if you see my cursor here, but essentially what I'm highlighting is a mitotic figure. It looks ugly. Okay, well, let's do some immunostains. This is SOX10 for neuroectodermal derivative. And you can see these are all of the tissue fragments. This is not even all the tissue fragments. I think there were 3 blocks, three FFPE blocks. This is the one that has the interesting histologic finding, just one tiny area. This is SOX10. It should be glowing, a nuclear transcription factor in schwannoma, and it is every single fragment. Here is the area of interest. Now, again, listen up. Only one area, this area of all 3 paraffin blocks showed this finding. Just this area. If you're a quick and dirty pathologist and you take one look at it and you make an instant schwannoma, and if you knew it was a dumbbell tumor, right? That morphology, spinal cord, schwannoma, and you stop looking, because you're lazy. You're not thorough. You would have missed it. You would totally have missed it. You had 3 paraffin blocks to look at. You look at one, look at another, and oh my gosh, well, you know what? Dr. Campbell did not miss this. All right, here's the SOX10 at high power. All right, you can see the top half of the screen. Look at all the positive nuclei in the schwannoma. Look at the bottom. No, these are all nuclei and they are negative. All right, little faint staining, you know, in the nucleolide side of it, negative. Not staining for SOX10. What does that mean? Probably not related to the schwannoma. All right, here's a CK7, keratin 7. Again, this is all the schwannoma in the left part, and this is our little cluster of cells, 4+ cytoplasmic expression of keratin. All right, and NKX 3.1. What is your diagnosis? Metastatic prostate carcinoma in schwannoma. Wow, based on one tiny microscopic focus. That is thoroughness. You like that? Oh, it's magnificent. Okay, what's your differential diagnosis? Now, do you even understand that question? I thought we just arrived at the diagnosis. We have prostate carcinoma in schwannoma. There is always a differential diagnosis. There's always a differential diagnosis. I can think of 3 possibilities. Listen, I can think of 3 possibilities to explain prostate carcinoma in schwannoma. 3. Number 1, floater. I don't know if all of the neuroradiologists and our radiology trainees, future body radiologists, are familiar with the path term floater. A floater is a contaminant during preparation and processing of the tissue. A little bit of one tissue can get in with the other specimen. It shows up on the slide. Usually they're completely unrelated tissues, if it's tumors, et cetera, 99.9 times out of 100. We do everything that we can to prevent that. We circle the floater on the slide and label it floater. Rarely it can be a disaster. And a disaster, for example, would be 2 different biopsy cases, say GI biopsies, which would look identical histologically in terms of tear. One of them has the cancer. It was a little floater. The other one does not. It was the opposite from the patient that they suspected would have it. And then it's a big morass. There's ways to resolve that. Okay, floater. Do you like that? Were you thinking outside the box, pathologist, to come up with that? Okay, well, listen, look, but more interestingly, how about this? Tumor-to-tumor metastasis and collision tumor. Those are both in the differential diagnosis. And in both cases, and even the floater, it's prostate carcinoma in schwannoma, but there's a big difference. Listen, there's a big difference between tumor-to-tumor metastasis and collision tumor. All right, do you know the difference between those terms? Can you apply them correctly? All right, tumor-to-tumor metastasis, we'll take that first. Typically a hematogenous metastasis of a recent high-grade systemic primary neoplasm to a long-standing low-grade primary neoplasm. Now, this is the same definition systemically. In the body, all the cancers in the body, they metastasize to each other with some regularity. We see it much less frequently in the brain tumors, but we see it with enough regularity that everyone needs to be familiar with it, all right? But typically, this is a principle. Think about it. This is the principle. You have a long-standing low-grade tumor. It's long-standing because it's low-grade, slowly growing, all right? That's going to be the host tumor. And then you have a newly arisen tumor, aggressive tumor, that metastasizes to it, all right? Most common recipient tumors, meningioma, number 1, pituitary adenoma, number 2. They both fulfill this criterion of being a low-grade, slowly enlarging, been around for a long time. Meningiomas tend to be more vascular, so they tend to be more, you see it more commonly than pituitary adenoma. All right, what about the most common tumors, metastasizing tumors, are carcinoma and melanoma, and the most common carcinomas are lung and breast. That's no surprise because they are the 2 most common systemic cancer carcinomas, so that's no surprise. But yeah, that's what the both the meningioma and pituitary adenoma, the 2 big ones are going to be lung and breast carcinoma, and of course melanoma. Okay, what's a collision tumor? A collision tumor is local infiltration of one neoplasm into a physically adjacent second neoplasm. So there's two different tumors growing at the same site, but separate initially. And then as they enlarge, they collide with one another and they mingle with one another. Okay? Question. Now that you are empowered with this knowledge, which does our patient have? Well, I'm going to eliminate floater. And the reason why I'm going to eliminate floater is because the patient does have widely metastatic prostatic adenocarcinoma. It's not a floater. It is real. Is it tumor to tumor metastasis or collision tumor? Well, I will tell you that I signed it out as tumor to tumor metastasis. I think that I may be wrong because that was before, and I did not have all of the imaging studies. Right? I think it might actually be a collision tumor, possibly, but I'm not sure. Why? Because of this, circled in yellow. There is, right here, as what is it, C6, C7, there is a vertebral body metastasis of the prostate carcinoma. I didn't have all the planes. I can't tell what it's doing. I don't know. But right there, right next door to this metastasis, is the schwannoma. And so it probably is, I mean, it could be, statistically, I'm not sure, but probably a collision tumor. Here's the point though, wasn't that regardless of which one it is, what a marvelous opportunity for us to examine both types of metastases, get the definitions straight, discuss the most common scenarios, and therefore your mind is going to be prepared should you encounter it, right? Okay, and I'm going to close, I'm going to finish the conference here by simply using that principle of tumor to tumor metastasis. Hematologic metastasis, a recent high-grade tumor to a long-standing low-grade tumor, and the most common recipients are meningeal pituitary adenoma. How about one more example of a different slow-growing, low-grade recipient with tumor to tumor metastasis, just to show it's not just meningioma and pituitary adenoma. Case report, Journal Neuro-Oncology, 2003, melanoma metastatic to central neurocytoma, novel case of tumor to tumor metastasis. All right, okay, wow. And here it is. Look at that, look at this imaging. Isn't that cool? You see on the left, the tumor is filling the left ventricle. Most of it is weakly to, iso-intense to weakly contrast enhancing. Look at these two foci. They were also hemorrhagic. All right, hemorrhagic foci, and here is the autopsy specimen. All right, photograph. This is from the paper. And again, you can see in the left ventricle, you have this homogeneous tan mass with these two here and here hemorrhagic foci. Okay. All right. Note to pathology residents. Note to the pathology residents and fellows. Photograph good gross specimens. They are priceless. Priceless. An H&E slide is virtually worthless in terms of being unique. You can generate 1.2, I quantitated them, 1.2 billion unique H&Es from a single 1 centimeter slice of a tumor for publication. As many publications teaching whatever you want. You can only publish a gross photo once, and then after that, you have to get copyright permission. I'm not talking about the author itself. I'm talking about when you go, listen, when you go to write papers, you want to write a chapter, maybe you're not going to do all that, but you have trainees that go out and they're going to ask you, do you have a nice gross photograph of meningioma? Because I've been asked to write a chapter on meningioma. The answer is no. Why? I publish them all because most pathology residents do not take the time to get the photograph, even at a place like MD Anderson Cancer Center, where we have an entire department, an entire unit of medical photography that generates magnificent photographs like the one that you are seeing here. Magnificent. Take the time. What if it's frozen section? And what if it's frozen section? You say, well, I can't get a gross photo because the place patient's on the table. I cannot delay the frozen. You don't have to delay the frozen. I mean, as long as the tumor is like even a half a centimeter, you can take a thin slice of the tumor, get cytology, get the yada, 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 all right, from the underside and photograph it as if it had never been mutilated. All right, let me tell you a little, and call medical photographers. You can keep both programs going. Let me tell you a horror story from about, I don't know, 15 years ago, something like that. One of our otherwise excellent, outstanding oncologic surgery pathology fellows was on the rotating neuropath service and went up first to to frozen. I was lagging behind up to frozen. I got up to frozen, and you know what I found? I found a bread loaf meningioma. So it was a gross total resection of a meningioma. I mean, meaning the dural border had been taken, beautiful, and it had been in situ bread loaf. Bread loaf for the radiologist means you slice, 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 just like a loaf of bread. And you might think, well, it was just a meningioma, and that would be a shame. And there was no photograph taken. That would be a shame. But you know, it was a bigger shame than that. Do you know why? Because you know what? Do you know what that meningioma looked like grossly? It was neon yellow, glow in the dark yellow. It looked like a lipoma. It was a lipomatous meningioma, metaplastic meningioma, lipomas. I have not seen another one. 28 years, some 28 years, I've been on faculty at MD Anderson Cancer Center. There have been one or two that showed a little bit of fat, yeah, but nothing like that one, mutilated. Now I put it back together. And I do have a photograph that's decent, it's passable, but listen, get the gross photos. Okay, let's move on. We're going to finish this conference. Okay, here is the central neurocytoma. You can see in the upper left, fried egg artifact. Remember, central neurocytomas mimic oligodendroglioma beautifully, right? But they're growing in the ventricle, not in the parenchyma. And in panel B here, they stain intensely for synaptophysin. In panel C is GFAP. You can see reactive astrocytes because they do arise, central neurocytoma, from the septum near the interventricular foramen Monroe. So there's going to be a border zone there. And also the neurocytoma cells themselves can, upon occasion, a subpopulation can express GFAP. They're neuroectodermal. There's no surprise there. Okay, what about the enhancing nodule? And here you can see the border in the upper left between the melanoma and the central neurocytoma. Higher power of the melanoma on the right, very typical. This is S100 protein on the left, panel C, and on the right, panel D is HMB45, melanoma marker. And then Ki67 is E at low power. Look how much brown there is in the melanoma. And this is a higher power. The Ki67 is about 30%. Everything fits. All right, now here's my favorite part of this paper. It's in the discussion. The present case illustrates the importance of thoroughly examining otherwise ordinary tumors, such as meningiomas and central neurocytomas, rather than simply taking a cursory glance and making a quick judgment. Holy moly, that's what I just said, wasn't it? I just said that. You have to be thorough, like Dr. Campbell, all right? Like, wasn't that a magnificent case of collision tumor or tumor-to-tumor metastasis? You will miss it if you're not thorough. And there is so much to see in the histologic sections of a garden variety tumor, meningioma, glioblastoma. There's usually something fascinating there to see. All right, now I went over it really fast. I meant not to show the authors. Everyone probably caught that. And here's my plan. My plan was to say, yeah, I really wish I knew which author made that statement. And then, oh, it was me. All right, so this was a case we published. Have a look at these authors. Heather Brown was one of our outstanding oncologic surgical pathology fellows back in 2003, now in practice. Ian McCutcheon, senior tenured neurosurgeon. The late, great Norman Leeds. Donald Schomer, the current chair of the Department of Neuroradiology. Mario Luna, the great Mario Luna, master of head and neck pathology, and modestly myself. This is an amazing group of authors for a case report. Boy, those were the days. And we miss and will miss forever Dr. Leeds and Dr. Luna. And I've said this many times in the past, I can never pay Dr. Leeds back for his training that he gave me in neuroradiology. Me and a lot of other people like Dr. Diana Bell, who's a head and neck pathologist, honorary member of the section of neuropathology. Dr. Luna was also one of her mentors. We cannot pay them back, but we can pay it forward, and we can acknowledge how important they were to us in our early years. And it's important to do so when you have the opportunity. Okay, that's it. Thank you. We are done. I haven't posted on Twitter, YouTube in a while, but I do have plans to get back in the game. And with that, I'm going to conclude the conference. Thank you to everyone who attended and to everyone who stayed. I will see you next week.